The first hour of the show, we will be speaking with some wonderful people, and we're going to be talking about pediatric cardiomyopathy, which is a topic not often discussed, but very, very important to know about. So we have some great information to share with you on that. So let me start by introducing my guests who are with me in the studio right now. I have Dr. Daphne Sue. She's a leading expert in children's heart failure and heart transplant. She has treated more than 600 children with heart failure and more than 250 children undergoing heart transplants. Dr. Sue is the chief of pediatric cardiology at Children's Hospital at Montefiore and a professor of pediatrics at Albert Einstein College of Medicine. Dr. Sue, thanks for joining me today.
Thanks for having me, Samantha.
I'm so glad you're here. And also joining us is Lisa Yu. She's the founding executive director of the Children's Cardiomyopathy Foundation, which she and her husband, Edward Yu, founded. She is the recipient of the Children's Hospital of New York Presbyterian 2005 Golden Heart Award and the Good Housekeeping 2004 Hero Health Award. Thank you for joining me today.
Thank you for inviting us.
So we have lots of important information. Folks, by the way, our phone lines are open. We'll be taking your calls throughout the show on pediatric cardiomyopathy, and just want you to know that so you can think about calling in over time. Dr. Sue, what is pediatric cardiomyopathy? I think it's a big, long name, and it's kind of scary, and I think most people may be unfamiliar with it.
Pediatric cardiomyopathy is a disease of the heart, and cardiomyopathy describes that disease. Myopathy because the heart is a muscle. It pumps the blood around the body. It pumps the blood to the lungs. And cardiac because it's the heart muscle that's diseased. It is a disease that affects children and adults. Unfortunately, it's a disease that does have a very significant impact on children's lives when they have it. If your heart doesn't work well, as you might imagine, the children don't feel very well.
Yeah. Now, cardiomyopathy, your heart's not functioning well. And you don't really think of children having heart disease. We always think of that as something that happens as you get older and you have high cholesterol and high triglycerides. What actually is different with a child's version of heart disease?
Well, that's a good question, Samantha, and a question a lot of our families ask us. The reason you have a cardiomyopathy when you're a child is not because you ate too many French fries or too many burgers, or because you felt that you weren't going to take care of your body and not be very well and healthy. But the reason children get the cardiomyopathy is because it's a genetic disease. It affects families and affects children who have really no risk factors at all. And it's a result of the fact that the heart is a muscle and it has to have energy to pump, and it has to have strength in the muscle to work. And sometimes the genes in the body are a little mixed up, and it crosses signals so that the heart doesn't pump as well as it can because it's not using the energy efficiently, or it's actually not able to get the energy to the heart in the way it should because it can't transport the sugar and the fat and the protein that you need to get the muscle working well.
So it's not like we hear sometimes of even in utero surgeries where they're fixing a valve, or it's not a sort of construction piece of the heart. It's the muscle function itself and how well the muscle cells can actually utilize blood sugar and electrolytes to contract and things like that?
Exactly. There are a lot of babies who have congenital heart disease, which I also take care of, that have a valve that's too narrow, something that's open that shouldn't be open that can be fixed. Unfortunately, this is a disease with a muscle of the heart, and each cell is diseased, and we can't fix and operate on each cell. So it has a lot of implications for how we treat the disease.
So cardiomyopathy, pediatric cardiomyopathy, is very serious. It's the muscle itself is diseased. It's not an abnormal structural problem, which we think of can happen with kids. Can a child be born with pediatric cardiomyopathy and the parent, the doctor, the child really have no idea that there's a problem?
Yes, that does happen, Samantha, because when you're inside your mom is really doing the work of the heart. You think about it, the mom gives the oxygen to the baby, the mom's delivering the blood, pumping the blood, so that if your heart's not working as a child inside your mom, you aren't actually going to have any symptoms. But once you're born and the heart has to take over, we can see symptoms of cardiomyopathy. So there are babies that are born, and really the babies less than a year old are one of the most common group that gets cardiomyopathy.
You're born with it. It doesn't show up later, or does it?
It can also show up later. There are things in your body that might not be stimulated or activated until you're older. So we see another peak in the diagnosis of cardiomyopathy when children are adolescents. I think of it because this is only my only theory. My own theory is that as you get bigger and start to really have to grow in adolescence, that's when you see the fact that the heart can't quite keep up. You might have been able to do it when you're 5 or 10 years old, but once you go through your teenage growth spurt, you'll see the heart say, whoa, this is a little too much for me. I can't handle this.
And do genes get turned on and off? Can lifestyle affect whether those genes get turned on and off? Do we know about diet, exercise? Can something the mom ate while she was pregnant or what the kids are eating growing up, can that affect whether those genomes go ding-dong or not?
I think very rarely this is caused by diet. There are some diseases where the heart doesn't work because you're not getting the right kind of nutrients to your heart. And if you change your diet, it can treat that type of cardiomyopathy. So it's not really that you're eating the wrong thing. It's your body can't metabolize some of the things that normal people can metabolize. So in that sense, there is often a dietary component to how we treat children. But it's not the cause of it in the same way we think of an adult person who ate, as I said, too many burgers, too much French fries, didn't take care of themselves, smoked, and their heart became diseased as a result of that.
Okay, just before, I don't want to forget to ask you this, and then Lisa, I want to talk to you in just a moment. You said there's some things that we can eat if we have a pediatric cardiomyopathy that may help the heart utilize nutrients more efficiently. Like what?
Well, that depends on the disease. We're really talking about genetic metabolic diseases where you can't use this type of sugar. You can't use this type of fat. You have to stay away from that. You have to eat more protein. So each one of those is tailored to the disease that we diagnose.
Okay. And are there many different kinds of cardiomyopathies?
There are many different causes of cardiomyopathies. Wow. The end result is a heart that doesn't work well. So children with cardiomyopathy look the same. They don't grow well. They have trouble breathing. They have rhythm problems in their heart. One of the leading causes of sudden death in teenagers is having a heart that has cardiomyopathy, because that cardiomyopathy makes the children more prone to having an arrhythmia in their heart.
And then the heart will stop. The only way to truly treat a cardiomyopathy, a pediatric cardiomyopathy, is how?
The only way to truly treat it is to replace it. Now, that doesn't mean that we have to replace the heart in every child with cardiomyopathy, because there are ways to make people feel a lot better. And we can make children with cardiomyopathy live quite a long time with a heart that doesn't work well using the medications we have to get rid of the symptoms. We use medications called diuretics that get rid of extra fluid in the heart. We can use medications that will help the heart pump better, called ACE inhibitors or beta blockers. There are medications that can help the heart rhythm be under better control. There are pacemakers that can prevent the heart from having an arrhythmia. So there are many treatments along the way to sustain the patient for years. But the ultimate treatment for it, to get rid of it, would be to take the heart out and give the patient a new heart.
So a heart transplant, which you do.
Which I do. I'm a cardiologist. I work very closely with my surgeons. I don't physically do the transplant.
But you work with a lot of
But I take care of a lot of kids afterwards, because you have to take care of the heart, manage the immune system, make sure that they stay healthy, to take care of that gift that they receive from their donor.
Wow. All right, folks, you are listening to us here at Dr. Radio, Sirius XM 81. We're in the heart of the NYU Langone Medical Center. I am here with Dr. Daphne Sue. She's a leading expert in children's heart failure, heart transplant. We're talking about pediatric cardiomyopathy. And Lisa Yu, who's the founding executive director of the Children's Cardiomyopathy Foundation that she and her husband, Edward Yu, founded. Now, Lisa, thank you so much for joining me today. And folks, by the way, I want to talk to Lisa, but we are taking your calls. If you have any questions, these are the people with whom you would like to speak. 1-877-NYU-DOCS. That's 1-877-698-3627. Lisa, you founded this organization. What prompted that effort?
Yes, Samantha, this disease, pediatric cardiomyopathy, has really affected our family in a very significant way. Unfortunately, my husband, Eddie Yu, and I, we started the Children's Cardiomyopathy Foundation in 2002 after we lost 2 young sons to this disease, to hypertrophic cardiomyopathy, which is one of the 5 major forms of cardiomyopathy. And so with our first son, he died unexpectedly, sudden cardiac arrest at 11 months. And we only learned of his cardiomyopathy after his death, post autopsy. And so with our second son, Kevin, he was fortunately diagnosed at birth, knowing the family history. But sadly, he died waiting for a heart transplant at 11 months. So, of course, what we experienced as a family kind of illustrates the two worst things about this disease, about cardiomyopathy. As we started working with more specialists in the field, at that point we were, desperately searching for answers. How did this happen to our family? And we learned that cardiomyopathy results in some of the worst pediatric cardiology outcomes for children with heart disease. And some of the statistics is that nearly 40% of children who present with symptoms of cardiomyopathy, they either receive a heart transplant or die within 2 years of diagnosis. And so we became this statistic. And
I'm so sorry. It's for anyone, whether they have children or not, it's just so heartbreaking. And knowing you had the second child and trying to do everything you could and still losing him is just, I think devastating is an understatement. And Dr. Sue, you knew this child. You knew Kevin.
Yes, I had the privilege of knowing Kevin and meeting Lisa and Eddie when Kevin was ill. I think that's one of the great challenges of being a heart transplant doctor, is not being able to find the heart in time. I think that's we talk a lot about donor awareness and knowing what kind of benefits you can give someone when some tragedy happens to your family. And Lisa's story is an example of what we talk about when we say you can really do a lot of good if you think about transplant for a loved one.
So for people, no one ever wants to think about losing a child, but tragedies happen, illness happens. What do people who are listening now who may want to say, gosh, I don't want anything to happen to my family, but if something does, being a donor would be a good thing to do. Where can they go? What kind of resources can they have, and what should they do?
Well, the first thing to do is talk about it in the family. I think it's very difficult when you have a tragedy to try to address issues that you never thought of before.
Yeah.
If you have conversations within the family talking about how you feel about what you would like to happen after you're gone, it really does help the family make the decision to decide to donate. Mm-hmm. There are a lot of great stories out there. There are a lot of great organ transplant information websites that people can go to if they're interested. Even just signing the form that says, yes, I'd like to be considered as an organ donor, mm-hmm. will make someone in the family say, well, gee, I know that, John really wanted this to happen. I'm gonna look into it. Mm-hmm. That kind of awareness really is, I think, the best thing to do, because you don't like to talk about sad things when you have a terrible tragedy in the family. And if you can talk about it when everybody's reasonable and say, gee, this seems like a good thing to do, mm-hmm. it's like any gift you give. I think that you can get a lot of good feelings about knowing that there might be something good coming out of some horrible tragedy in the family.
So, Lisa, that must have been so tough for you, waiting and waiting and waiting. And you're waiting for something that you want to have to save your child, but you don't want anything to happen to another child.
I think that is the very difficult part for some of the families that are, waiting for a donor heart for their child, because where that donor heart came from. Yeah. Another child had to die to give life to your child, possibly. So, with my work with the foundation, many of our families, they are on the heart transplant list, waiting for a donor heart. And it's always such great joy, of course, once they get the call, that the donor heart is available, but it's also bittersweet. And I think Dr. Sue knows, because another child had to die to have that gift. Provide that gift of life for someone else. But I do want to add that with cardiomyopathy, this was our family's situation with the disease, but it's not always so severe for every child that is diagnosed with that, and that I want to be very clear about, because we do work with many families that have kind of more successful outcomes. Now, maybe the disease does not resolve itself, but they are able, with medication or sometimes, implantable defibrillator, they are able to somewhat control the disease. There is always the chance that the disease will progress. So there is a lot of anxiety, revolving around the disease. But, there has been some progress in the field. So we are kind of, in a better situation to treat children with cardiomyopathy.
And a lot of that is due to Lisa's work in the Children's Cardiomyopathy Foundation. The disease is a very rare disease. Not a lot of people are affected by it. People are not perhaps as aware of the needs for research. And Lisa has done a great job to tell us in the field, this is something we have to think about. Cardiologists, be aware of it. She's funded research for people to know how to best take care of the patients. And she's also funded research for us to try to find out the fundamental origins of the disease so that we can say, now we can treat it. We're not quite there yet, but we're starting to come along to say, oh, it's this problem in this mitochondria. Oh, it's this problem in this part of the connective tissue. Once we know that, then we'll be able to say, oh, maybe this medication would work. Maybe this is where we can make an impact. So that's, I think, the even more sort of the way we're really going toward is getting rid of the heart transplant as a solution to try to figure out how to treat the disease and keep your own heart.
Right. What is the do we have a statistic on one out of how many children may have pediatric cardiomyopathy?
It's a pretty rare disease. It's about 2 out of 100,000 children are diagnosed with the disease.
And you had 2. Oh my gosh!
Right, and but I do also want to add that that published data, the issue with cardiomyopathy is there are kids that are not diagnosed. So there are some children.
Could be more.
Right. So that number captures the kids that are diagnosed, correct? And and Dr. Su mentioned that cardiomyopathy is the leading cause of sudden cardiac arrest. So a lot of times we work with families where they only learn about their diagnosis after maybe their child has suffered a sudden cardiac arrest or has died. And so, there are, other kids that perhaps are at risk that haven't been accounted for.
Right. So if you have a child who has cardiomyopathy, do they have to be on a special diet? Can they play sports? Can they run around and have an active life? Do they need to be, put in a room and be quiet? And, how do you treat this?
Well, it's a good question. I think that's a question parents are always asking us. We are always trying to make the children have as best and normal as life as possible. Now, obviously, if your heart doesn't work as well as somebody else's, you're not going to run the marathon. And there might be a danger that if you really tried to push yourself, your heart would have a rhythm problem. You could have a sudden death episode. So we are very careful to counsel our kids about extreme sports or even competitive sports as you get into high school where people are pushed beyond their limits. Those children with cardiomyopathy can't play those sports. That does not mean they can't have a healthy lifestyle. But we encourage them to play, play outside, to play with their friends. They always have to eat a heart-healthy diet. Nothing in particular, but we're very careful to say, why give yourself another problem in your heart? Take care of it, eat well, so you're not compounding the problem by adding on any acquired heart disease you might get as you get older.
We know with regular cardiovascular exercise that, for example, the heart adapts, which is real, and it does great things. For example, it generates new collateral vessels, so you can bring more blood to the heart. So one would think with cardiomyopathy, some cardiovascular exercise that wasn't pushing too hard could help the heart muscle grow stronger, maybe grow some of these collateral vessels. But how does that help with the progress of cardiomyopathy? I know it's different, obviously, with every diagnosis, but it can't hurt?
Exactly. It can't hurt.
If it's done appropriately, right?
As long as it's done without pushing yourself too far. So the idea of building more collateral vessels and improving the cardiomyopathy is really something that's not going to happen in a genetic disease like it might happen in somebody who had a heart attack. But it will make the children just feel better and healthier. As we know, kids who move around and are active are going to have a better sort of attitude toward life, and they're going to be able to feel a lot more empowered. So that's why we do tell our children, no, go out there. We'll tell the schools, let them be out there in gym. Let them play the kind of sports they want in the recess. Now, there's some children who can't. There are some children whose hearts don't work well enough for them to actually be able to do that. That's when we start talking about the impact of cardiomyopathy on their quality of life. And that's when we start talking about what can we do to make that better. And at some point, that's when we say a heart transplant is going to give you a lot better quality of life than you have right now.
So for the kids who can run around at recess and play, are they still destined for heart transplant later on?
It's always a tough question. When I say to my children, I want you to be around when you're 90 years old, right? Do I think they'll be around with that current heart? If they have a severe cardiomyopathy, I think probably not, that the heart may be replaced, but they'll be around. And I think that you have to talk to families just like you would talk to anybody else, tell them you don't understand the future. You don't see the future as clearly as you'd like to see them, but you're sure that when the future comes, there'll be something there that will help them.
Okay. Now, Lisa, you mentioned there's 5 kinds of pediatric cardiomyopathy, and hypertrophic cardiomyopathy was what your son suffered from. So my first question is, we say it's genetic and it's there's now a family history, but do you know anyone on your side of the family or your husband's side of the family that may have had this and it went undiagnosed?
Right. Well, with our situation, my husband does have hypertrophic cardiomyopathy, so we did know this. But I think back then, it was in 1997. And 98, I think there wasn't a whole lot of information about the disease, about the genetics about the disease, and also just how does it affect other family members. So when I was pregnant, I did tell the doctors that there was this family history, but we didn't know enough about the disease. So with my first son, I remember taking him to the pediatrician and asking him and reminding him that, okay, my husband has this disease, this heart disease. What should I do? When should I start screening him? And the response at the time was, well, really young children don't really get this disease. So don't worry about it. We can screen him when he's a teenager, which is the more, typical age where this disease might manifest. So, and unfortunately, 1 month later, he died of sudden cardiac arrest. So when we brought him into the emergency room, they really did not even understand why he was under cardiac arrest. So, that was our situation. We didn't know enough about the genetics to ask these questions. At the time, no one had suggested that we go see a geneticist. So that's another thing that, I would advise families to. We always say, understand your family's cardiac health history. Ask those questions of, is there anyone that was under the age of 50 that died suddenly that didn't know what the diagnosis was? Was it maybe heart related? Anybody in the family under 50 that has a heart disease currently? And then just, I think, asking those questions and then going to their family physician, and asking them, should I see a geneticist? Should I see a specialist, a cardiologist, and just explore this? Who should be screened in my family? Because I will tell you that a lot of the families that we work with, the child is diagnosed first, and then only through further family screening or perhaps genetic testing, they find out that the parent has it. Or another sibling has it, and they never knew that, because with a genetic disease like cardiomyopathy, you could have the genetic mutation, and you may not ever have the actual disease.
Right, it may not turn on.
Right.
So with her husband, Edward, having cardiomyopathy, the physician, I'm guessing, thought it was an adult problem, that he wouldn't have had it. It wouldn't be pediatric because he was a grown person, so he didn't extrapolate that information to children.
Yes, I think that we've learned a lot about genetics in the past 20 years, and we've learned a lot about pediatric cardiomyopathy. And the awareness of the disease, because it's so rare, is quite low in the general medical community, let alone the general community as a whole. So that it's not surprising that someone might have said that.
Right.
I think these days everybody is much more aware of how you can inherit it. So there's a much more big push toward having people evaluated and children evaluated sooner. So right now we recommend that if somebody in the family has a cardiomyopathy, that everyone in that family be screened. That would be everyone around, the parents, siblings, and children of that affected individual. The NIH is actually sponsoring a study right now for us to look at the genetic underpinnings of cardiomyopathy, to use the new genetic testings that we have to see if we can identify exactly where those genes are, do they cluster together, and try to find out why in some patients, if you have the genetic defect, you don't have the disease at all, and why if some others, when you have it, you really do have a very affected infant.
So we'll take a break in just a moment. And folks, by the way, our phone lines are open here on Sirius XM Doctor Radio, 1-877-NYU-DOCS. It's 1-877-698-3627. If you have a question or family history of cardiomyopathy, we'd love to hear your experience or answer your questions, so give us a call. So I'm sort of going back to the fact that your husband is an adult male with this. Now, was he then born with this and he's just grown up with it and it didn't get really bad ever? Or did it manifest later in life? And if that happened, then you extrapolate to children. I think for people that I'm a little confused by it.
Right. Those are great questions. And I will say that our family situation is very unique, and it's a complicated case. With my husband, we don't know if he was actually born with it because with his side of the family, there was no obvious family history. We could not identify anybody else that ever had cardiomyopathy. But there are cases where you can develop the disease through, they call it a spontaneous occurrence, right? And it starts with that one individual, and they develop the genetic mutation. So my husband has a very mild case of cardiomyopathy, and it was only discovered because when he was young, he had basically they call it a hole in the heart, atrial defect, and he had open heart surgery for that. And because of that, he would have to go to the cardiologist every year. And it was only at those annual visits that they discovered, he has borderline hypertrophic cardiomyopathy. But he never really had any major symptoms. Of course, he was told he could not do wrestling anymore, right? He couldn't do competitive sports. And he, is doing well now. It was only after our son's diagnosis that they put him on medication, knowing the history. But otherwise, he's doing fine. But that is the complexity about the disease, is that you could have the same disease, but it can present very differently in family members. So our sons had it very severe. My husband has it very mild. And I think some of the families that you see, Dr. Sue, similar.
The same thing. I think what we're learning about genetics is it's not one mutation. People used to think, it's like peas. You're a red pea, you're a green pea, and it's just that one gene. We're finding out that it's the gene, plus it's all the other genes in the body. It's the combination of the parents, and it might be even in your environment. Is it not exactly your diet that you ate too much of this kind of food, but it may be that your environmental influences somehow also do affect whether or not you get more or less hypertrophy. That might be whether you have hypertension. That might be whether or not you're a drinker or a smoker. It might be all different things that could affect how these genes are turned on and turned off. So it is one of the challenges. Is we like to be anticipatory. We don't want to miss something. We don't want something terrible to happen because we didn't know. But we also have to say, well, we also don't know when we find it whether or not you're going to be a person who would have gotten sick now or you wouldn't get sick for the rest of your life. But I'm a big believer in you should know a little more than a little less about what might happen to you, because that can only help people if there's something that happens in the future. It can help interpret what happened to Lisa's son. If they had known he had cardiomyopathy, maybe you've been watched a little more closely.
Yeah. All right, folks, when we come back, we're going to take a short break. Dr. Daphne, Sue, and Lisa, you are still with me. We will be taking your calls here at 1-877-698-3627. And we will talk to Lisa about what the future then brought her after the death of two 11-month-old sons. The future has been better for her, and she started this new organization, and we will talk a little bit more about that, what you need to look for. We're also going to be exploring a little bit about what happens with teens and when they play sports and what to look for. So stick with us. We're going to be taking a very short break here on Dr. Radio, and we will be right back. Hi, everybody. Welcome back to Samantha Heller's Health and Nutrition Show right here on Dr. Radio, Sirius XM 81. We are in the heart of the NYU Langone Medical Center in New York City. Thank you so much for tuning in. If you're just tuning in, we are talking about cardiomyopathies in children and adults, where they come from, what happens, and how how to find out if you are at risk. And we'll be talking about all of that with my wonderful guests in studio with me today, Dr. Daphne Sue. She's a leading expert in children's heart failure and heart transplant. She's the chief of pediatric cardiology at Children's Hospital at Montefiore and a professor of pediatrics at Albert Einstein College of Medicine. And also with us is Lisa Yu. She is the founding executive director of the Children's Cardiomyopathy Foundation, which she and her husband, Edward Yu, founded. So we're talking about that today, and we are taking your calls, 1-877-NYU-DOCS. That's 1-877-698-3627. We have lots to talk about in the second half of the segment, but we do have a caller, so I want to get to our caller first. We have Sandy from Arizona. Hi, Sandy. Thank you for calling and listening to us here at Dr. Radio.
Sure, you bet. Thanks.
What can we do for you?
Well, my brother was diagnosed with, they called it back then, idiopathic non-ischemic cardiomyopathy in I think it was 91 or 92. And just prior to that, I mean, he's a real healthy guy, like a former Marine, a runner. But I remember him saying he had this choking sensation in the night that would wake him up. And when he went in to the cardiologist, they noticed he had an enlarged heart in the left bundle branch block, and the workup, indicated that he had the cardiomyopathy. And then he went downhill quite quickly, and in those 18 months, he got a transplant at the University of Michigan. And he did quite well. I mean, he was very active prior, and he resumed that life. He was like their poster child. He would go visit the new patients to kind of pump them up.
Aww.
He did pass away just before his 20-year anniversary with his heart.
I'm sorry,
he had
honey.
had a stent put in a couple of months prior to his death, and it was a sudden cardiac thing where he just fell right down in the middle of his work and broke his nose and was gone. And the day before, he was helping his neighbor chop 30-foot trees, and he was the one climbing the trees. So that's how much he lived his life. And then later, my mom, in her 80s, began to show problems like kidney failure. There was some kidney failure, some of her chemistries were off, and they realized she was having a low flow problem. She also had some ischemic bowel, that she too had a non-ischemic cardiomyopathy. And they were like, how unusual in one family. And now there's 4 surviving siblings, and I didn't make that connection I do remember them saying that, but no one said, you guys should get
screened.
Checked out.
Yeah. So, Dr. Sue, should Sandy, her siblings, their children, the cousins, all get screened? And if so, what are the screenings that they should be getting?
Well, hi, Sandy. Nice to meet you over the phone. I would say, yes, Sandy, you should be screened because you might have inherited it, especially since your mom had it and your brother. The screening is not a big deal. People will just look at you, do an electrocardiogram and an echocardiogram to make sure you don't have any signs of dilation, which is a big heart, and no signs that your heart is working less well or lower ejection fraction. In terms of screening the other people, the people that should really be screened would be your brother's children, if he had any, to make sure they aren't affected. And whether or not you screen your children will depend on what they find in you. If they don't find anything, then we're not recommending that everyone else be screened. That's not to say it doesn't skip generations or skip people. And as we said, you can be affected and have the gene and not show any signs. But from what you're telling me, I'd say I'd start with you first. That would be the real important screening would be you and your other your brothers and sisters.
So I have a question about her brother who died of sudden cardiac arrest with a different heart. What?
It sounds like her brother had a typical, as I say, a typical side effect or a typical thing that happens to transplanted hearts after a long period of time. The coronary arteries in a transplanted heart are from the donor, and it is very typical for the body of the recipient to start to try to narrow those coronary arteries as a form of rejection.
Oh, but it happens over many years.
It happens over many years, and it is one of the reasons that we lose patients who have heart transplants.
Is 20 years sort of a benchmark for that, or?
If you look at the information, about 50% of the people who get a heart transplant won't have that heart still inside them between 10 and 15 years after the transplant. So by 30 years, we kind of think those hearts are going to be worn out. I have great hopes that we're going to have a mechanical heart that's going to sustain people for a lot longer than just a few years. Right now, even retransplantation is something that we do. I have a patient that has had a transplant 4 times since he was small.
Oh, my
and
gosh.
He's doing well.
And he's doing well. Wow. So, Sandy, does that answer your question, dear?
It does, because, when my brother was first diagnosed, I don't know if I mentioned the year before, he had a bad influenza, and that's what they surmised caused this. But until we kind of went on that, but this whole genetic thing is definitely new.
Yes, and I think that's what we were talking about, the epigenetics. Perhaps your brother had in his body the gene that made the heart a little weak, so he was the one that got the cardiomyopathy after he had the flu. And we were just talking at the break that there are people who do have cardiomyopathies because they've gotten a cancer drug or because they've been exposed to some toxin. But not everyone with that cancer drug got that cardiomyopathy. So I do think there's a component of genetics and then a component, like you said, of something in the environment that stressed the heart.
So he could still develop a cardiomyopathy from a chemotherapy treatment or a virus without having the particular genes that you look for?
We don't know enough about the genes to look for all the genes.
Yeah.
We're always puzzled. Why does this child get a cardiomyopathy and that child doesn't?
Yeah.
And it might be the dose of the drug, but it's usually not because we give very similar doses of drugs. So there must be something in that child or something in that child's heart that says, whoa, I don't like this.
Okay.
And I'm affected a little bit more than other kids who got even a larger dose of the chemotherapy.
So Sandy should see a cardiologist.
Yes.
Okay. So Sandy.
Okay, great. Yes, thank you very much. I'll do that.
Thank you for sharing that. That was really good information. And thank you for calling and listening to us here at Dr. Radio. We have Anna from Pennsylvania. Hi, Anna. What can we do for you?
Hi. I'm just calling because my son, he was born in July, and they do a pulse oximetry test now for every baby at the hospital in Pennsylvania, and he failed it. But everyone was shocked because he looked fine, no blue, no clinical symptoms of anything. I mean, he was absolutely fine. So they redid the test. He passed it. We were in, about 2 weeks later, we were there for something else, and he failed the routine when they did again. We actually had an echocardiogram in the hospital. Then after he failed it again 2 weeks later, we went back and had an echocardiogram. He was on a pulse ox monitor the whole time for about 4 to 5 hours, and his pulse ox stats dipped from, down into the 80s, while he was on the monitor. And it's just really odd. He has a PFO, and I think it's a left to right shunt, which is normal for a lot of infants. Sometimes it closes, sometimes it doesn't. But I don't know if there's anything in there that could be something like this that they're missing. It just, the cardiologist said when they started doing a pulse ox, she thought that they would get a lot of false positives, and she said they just don't. She said that, they fully expected him to have some sort of congenital heart defect, and there's nothing they can see.
Sounds like you've become quite a medical expert, haven't you, Anna?
Yeah.
I love my kids.
Exactly. Obviously, there's a great concern when the oxygen saturation is low that the blue blood is mixing with the red blood, and that would be what they call a structural congenital heart defect, a hole in the heart that's going the wrong way, or a valve that's closed. And you should be very glad that your son doesn't have those. The echocardiogram is very good for detecting that kind of disease. It is not a sign of cardiomyopathy to be blue. So I wouldn't be worried that your child has a hypertrophic or dilated cardiomyopathy. And also an echocardiogram is very good for diagnosing that. Now, why he has a low saturation is always a big question, isn't it? As long as he's fine and doing well, I bet they've said, we're just going to keep watching him, right?
They did, yeah.
They did. And that's, as I always tell my patients, that's a good place to be because you don't actually want to be a person who has anything found that we're looking for because those are pretty serious. But I'm sure they want you to keep following up just on the small chance there's something else going on that would make him a little bit blue.
He wasn't blue. That was the thing. He never has turned blue.
Right. Well, that's reassuring, too. So the saturation
it's just weird.
Exactly.
Would it always be then? And a pulse ox for our listeners is just a little device you put on a finger, and it measures how much oxygen is in your blood and how well your body is extracting oxygen when you breathe in and out. Is that a fair explanation?
Yes.
So could it be a lung problem and not a cardiovascular?
No, I'll tell you why. 2 reasons why. Number one, they did a chest X-ray and it looked normal. But number 2, his pulse ox actually dipped when he was crying, which, as you know, if you're crying and it's a lung issue, that should not make it dip because you're getting more oxygen, your lungs are open. So they do not think it's a lung issue.
It sounds like they've looked for lung issues. That you're right, Samantha. It could be a lung issue. It's interesting that it fell a little bit when he cried. It sounds like maybe there was a little blood flow through that ASD they told you about, or that PFO, and maybe that will get better as he gets bigger, because sometimes it does make blue blood go to red when they're young and then get a little better when they're older.
Will you tell our listeners what PFO and ASD is?
Yeah, sure. So PFO is you're talking about a little hole in the heart called a patent-foraminal valley that's there. I'm sure your doctors told you, Anna, because every single fetus has it. It's a way for blood to bypass the lungs, because obviously fetal babies are not breathing. So that hole always takes blue blood over to the red side, but somehow in your son, Anna, it sounds like it might be doing it even after he's born. And I have seen that. And then it slowly gets better. A little unusual, but I'm hoping that was what it is, because that would be a very nice thing. It will correct itself.
And certainly, and Anna, it sounds like you're seeing some excellent pediatric specialists, and that's what you want to be doing in this case. So thank you so much for calling, and good luck, and I hope the baby gets healthier every day, and so your anxiety decreases as well. And thank you so much for calling and listening to us here at Dr. Radio. Lisa, callers, I will get to you in 1 second, but we were talking about your loss and your foundation, which is the the Children's Cardiomyopathy Foundation, and that you started with your husband because you lost 2 children to this disease. But tell us what's happened in your life since then.
Since we started the foundation, that was 12 years ago, so that's been very, very busy with me, and we're focus on all forms of cardiomyopathies affecting children. So we're working in the areas of research, education, providing family patient support, and also looking to increase awareness of the disease, and also advocating for the needs of families with affected by cardiomyopathy. So there have been many things that we've been working on in terms of the foundation, and I can talk a lot about that.
But in your personal life?
In my personal life, yes. So my husband and I, after losing our first 2 kids to cardiomyopathy, I mean, we were very blessed to have a family. We have 4 children now, and they all seem to be heart healthy. They range from age from 6 to 14. So I feel very fortunate. I did not want to give up my hope of having a family, and
that's such great news.
Thank you.
And very courageous on your part too, I think. Yeah.
Thank you. 2 of our kids are adopted, and 2 of our kids are biological, and but we do have to continue to monitor their heart to make sure that they're okay, and so far they are, but in fact I have to take them to the cardiologist again next week, so just to make sure that everything's okay, because with cardiomyopathy, as I mentioned, you could have the genetic mutation and just not know when the disease will show up.
And we don't always have a specific gene, Dr. Sue, as you were saying, to test for. So it's not like with breast cancer, we look for BRCA1 or BRCA2. With cardiomyopathy, we're not totally sure.
Hundreds of genes.
We don't know what we're looking for.
And we don't even know them all.
Yeah.
Right.
Yeah.
I mean, they do have genetic testing, but for the most common forms of the genetic mutations. But again, as Dr. Sue said, there are, hundreds, and not all of them have been identified. But as a foundation, we continue to, try to fund the research to try to identify more mutations. If
someone wants to know more about your organization, do you have a website that they can go to?
Yes, we do. So it's www.childrenscardiomyopathy.org. They can also visit our Facebook page, Children's Cardiomyopathy Foundation. We also have Twitter at CCF Heart Kids. We also have a hashtag Know Your Heart. I think they can find us if they Google us,
okay.
And we're here to help anyone with any questions.
And you have a happy and thriving family. And I really just wanted our listeners to know that, because you've been through a lot, and you've sort of not only taken your tragedy and bounced back to have a wonderful family, but you've bounced back and created a foundation to help other people cope and help find answers to things that had happened to your family. So thank you so much for that. That's pretty fabulous.
Thank you, Samantha.
And we are taking your calls here, 1-877-NYU-DOCS, 1-877-698-3627. You're listening to us here at Sirius XM 81 in the heart of the NYU Langone Medical Center. We have Joanne from New York. Joanne, thanks for calling.
Oh, thank you for taking my call.
What can we do for you?
I am 60. And about 5 years ago, I had very bad fatigue, and to cut to the chase, was diagnosed with a hypertrophic cardiomyopathy with a 15% ejection fraction, and was worked up for that, and have been doing fine. But I'm not sure whether my kids should be screened for it, or I'm not sure.
And so, Joanne, this is Dr. Sue. I think, yes, your children should be screened for it. You have gotten the disease as an older person, so that's not the same as having developed it when you're an infant, but your children are at risk because it is a disease that in some families is inherited, they say autosomal dominantly, that if they get one gene from the parent, then people will have it, and it can be silent for many years. So I would encourage you to have your kids screened.
So anyone of any age, I'm asking, who's been diagnosed with any kind of cardiomyopathy, their children should be screened. Yes.
Right. And my son was born with a VSD, which did close on its own, but he has not, they didn't say that he needed to be, screened or anything for the rest of his life. Like, he was fine, given a good
bill of health.
Yes, a VSD that closed, they were perfectly right. You don't need to keep following because it was closed, it's closed.
Right.
And obviously he didn't have hypertrophic cardiomyopathy then because he probably had an echocardiogram then, and they didn't notice it. But it is something that even though you carry the gene, it can come up, and so you would want to have him screened now. And it's just
how about grandchildren? I know I had one of my grandsons was born with a significant. I'm not even sure, but it was a murmur that needed to be followed till he was 3.
Right. Again, unlikely that he has hypertrophic cardiomyopathy because I bet he saw a cardiologist and they already did the echocardiogram, which is how we screen for it. But if your children don't have it, it would be less likely that their children have it, that that your grandchildren would be affected. But the first step is to sit back and look at everybody in the family pretty carefully. That's looking at your siblings, your parents, your grandparents, their siblings, because when we sit down and talk to people about their families, that's when we find out about, Uncle so-and-so, well, he died, and we don't really know why. And then we get our antennas up to say, maybe this was a familial cardiomyopathy that people just didn't recognize way back when.
Right.
All right, Joanne.
Thank you very much.
Thanks for calling, and thanks for asking that good question. Thanks for listening to us here at Dr. Radio. We have just a few more minutes left. We've talked about screening. Now, I just really, if you can condense a lot of information in about 10 seconds. We hear about young athletes with cardiomyopathy kind of keeling over, people running marathons, or our New York City Marathon is coming up. How do we know when to screen if you don't have a family history or you don't know that you have a family history?
Well, that's one of the reasons you have your yearly pediatric check. And during that check, as children are getting into the age where they're competing very high, in high-level competitive sports, those pediatricians are doing a screening. They're asking you about your family history. They're examining you to see if you have a murmur or any signs that there would be a large heart. And they're also asking the children if they have any symptoms. And those symptoms would be unexpected tiredness, trouble breathing, palpitations, dizziness, or fainting with exercise. If any of those symptoms or signs are found, then those patients should be referred to a cardiologist to screen for the disease.
Now, I think that I've heard, and I'm vaguely remembering this, so I may not be accurate, of athletic programs just sort of in general doing echoes on athletes. Is that happening? Is that a good idea?
It is not at the moment generally accepted that that's the right thing to do.
Right.
I think there's a lot of downsides to screening for something and finding a lot of untoward things that you didn't want to find.
Right.
So that's the opposite of what you would hope for with screening. So not everyone needs an echocardiogram, but anyone who has any signs or symptoms that might suggest that there could be a cardiomyopathy or a family history, those people should be screened, and often those kids get echoes.
Okay. Lisa, we have about a minute left. Do you have some final thoughts you want to share?
No, I think, everything has been covered. I think the two most important things for families to remember is to, look at your family cardiac health history and just be aware of the signs and symptoms of cardiomyopathies. And then I think those two information together, we can help to identify more at-risk children and hopefully save more lives.
And you can go to the Children's Cardiomyopathy Foundation website for more information, right?
Yes.
And some final thoughts you want to share as well, Dr. Sue?
I think that it's important, as Lisa said, for everyone to be sure that they have a heart-healthy, heart-aware life. And that's really why we're advocating for people to talk about that in their families and to share health histories so that you understand what you might be at risk for.
So a heart-healthy life, folks, those of you listening, what am I going to say? More plant-based diet, get your fannies up, get moving, jump up and down, don't smoke, of course, right? They're laughing at me, Lisa and Dr. I want to thank Dr. Daphne Sue for joining me today, Lisa Yu for joining me today. Thank you so much for coming in and talking about this important topic.
Thank you for having us.